Hi, folks. Welcome to the Health Research Live. My name is Marco Staffney. I'm the Executive Director of the Montshire Museum of Science and your host today. Our program is produced and organized by the Montshire Museum of Science, the Public Health Council of the Upper Valley, the Dartmouth-Hitchcock Norris Cotton Cancer Center, and Dartmouth-Hitchcock Population Health. Health Research Live is a program series that features community and regional scientific research about public health. But what exactly does the term public health mean? Today, Aurora Drew from the Dartmouth Institute for Health Policy and Clinical Practice and Alice Ely from the Public Health Council of the Upper Valley will examine public health from both a world and local level. Furthermore, they'll discuss how the COVID-19 pandemic has impacted public health efforts in our community. Aurora, if you wouldn't mind advancing the next slide. So how exactly does it work? Health Research Live is a program in which each presenter will talk for about 15 minutes. Then we'll be breaking up into individual Zoom rooms so that you can have smaller group discussions about what we've heard for about 10 minutes. Then we'll come back to a broader Q&A that we'll host through the chat feature. And without further ado, I'm going to hand it over to Aurora and Alice. Take it away.
Hi, everybody. I'm Aurora Drew, and I'm happy to be here today. Thank you very much for the invitation to talk about this. So both Alice and I are going to be talking today. I'm going to start with sort of more general talk about public health, and I have a bunch of audience interaction planned. So if you've got a phone that texts, you may find that handy to have. You also can interact online, and then we'll also do a little interaction in the chat as well. So we're gonna jump right into this thing. Thank you very much for joining us. All right, so we're gonna jump right in with a poll, and hopefully you can see this poll online. We're sort of pushing technology to its limits here. The instructions for responding are in your chat as well. So the question for you is, what is public health to you? And you can respond, and we'll start seeing your responses as soon as you start typing us anything. You can respond on the web at pollev.com/AD97 or by texting AD97 to 37607, and then you can text your message. And I encourage you to submit multiple answers because, as we know, public health is not one thing. So please submit multiple answers. And if you see something on the screen that you think, oh yeah, I agree with that, feel free to type that word again, and you'll notice it will get bigger as you type more responses. And I'm just going to pause here for a minute or so to give people a chance to text things that you think of when you think of public health. I do appreciate the people who are putting hyphens between their multiple word responses because this particular technology breaks up anything you put a space between. Oh, look at that big data. Somebody's after my heart. Big data. I also see that confusing on the side, which I can really understand right now. There's been a lot of confusion about public health guidelines during the COVID-19 pandemic. And I think that many, many people are feeling confused. Interesting. Press conferences. I'm seeing COVID-19 tracking. Yes, that's brought a lot of people's attention to public health. Science. Yes, public health is science. Vaccinations and vaccines are appearing there. Whole health. Doctors, guidelines, social determinants of health, tracking disease, health for everyone, keeping people healthy, doctors, guidelines. Okay, wonderful. Okay, I'm going to give you like another 10 seconds to type your last couple things so we can see it before I lock it. All right, I'm locking it right now. So, oh, look at that. Policy has gotten really big. Data, science, community, and a confusing got even bigger. I think other people are feeling confused as well. All right, this is really this is a great combination of things that all are related to public health. I see grassroots on the side as well. Okay, now I'm going to advance to what the CDC says are the 10 essential public health services. And these were just updated in September 2020. So if you've ever seen these before, they might look a little different than you did the last time you saw them. So they are 10 services that fall in general buckets of assessment, policy development, and assurance. You can see those words around the outside of this pinwheel here, this very colorful pinwheel. Under assessment, we see assess and monitor population health. That is the data, the big data word, I think that many of you typed in. We also see investigate, diagnose, and address health hazards and root causes. And then under policy development, policy was a big word on our word cloud, using communicate effectively to inform and educate. And it's possible we're not doing that well enough right now, and hence the confusion we're seeing in our word cloud, right? Strengthening, supporting, and mobilizing communities and partnerships. Alice will be talking a bit more about that in her segment. Creating, champion and implement policy law plans and laws. Those are all really important public health services. Utilizing legal and regulatory actions. And then in the assurance section, there's 4 other things: building and maintaining a strong organizational infrastructure for public health, improving and innovating through evaluation, research, and quality improvement. That includes lots more data, also probably related to your data segment on the word cloud, building a skilled and diverse workforce, enabling equitable access. And then you'll also notice in this pinwheel right at the center is this idea of equity. Equity is something we think about a lot in public health from many different perspectives of equity. Here in this region, we often talk about rural health equity. There's also racial health equity. There's many different kinds of health equity that we think about in public health, and that impact the ability of people to maintain health. All right, so next little interactive thing we're going to do is answering this question. Who does this work? Who does it? And this one you can put just put it in the chat. So if you don't see the chat right now, you probably have a little Zoom bar. It might be right underneath my face right now. Often it is. And if you just click on either more or the chat, you get to see the chat. And then please enter into the chat. Who does this work? Alice is saying epidemiologists. And I will say, yes, epidemiologists do this work. And I'm really excited that people now know what epidemiologists are. I have to say in, 2019, if I said, hi, I'm an epidemiologist, most people thought I studied the skin, not diseases in a population. So it's really wonderful to see that people now know what epidemiologists are. All right, I'm seeing health educators, doctors, nurses, community nurses, social workers, dietitians, health admins, researchers. I think there are many, many people who do this work. Community health workers, yes. There are many, many people who do this work, and some of them get paid to do this work, and some of them don't. Alice put civil engineers, and I like to think about somebody related to civil engineers, actually. So think about when you're driving through a construction zone, which we seem to have plenty of in the summer in the Upper Valley, and there's a person who is standing at the end of that construction zone and telling you when you should stop and when you should go. Are they a public health worker or not? Anybody want to vote? Is that person standing at the end of the construction zone telling you when to go in your car and when to stop? Are they a public health worker? Nobody's willing to jump on that one, huh? Laura says yes. Steve says yes. I would wholeheartedly say yes. And their job is to protect us from harming ourselves by misunderstanding what we're supposed to do. They have a communication job that is really directly related to our chance of injury in driving through a disrupted traffic pattern during a construction zone. So yes, I would say that there are a lot of people who do public health work, but probably don't think about themselves as public health workers. I love Steve's response, which was neighbors. And that brings up my point that just about everybody is involved, whether you're paid or not, in maintaining public health. We all have a role in this work, whether it is in our job or whether it is just the work we do in our families, in our communities, in our small social networks, or in our large social networks. We all can be part of the solution for public health. My point here is that a lot of people do this work beyond the people you might think of and beyond the people who get paid. I'm guessing you're here because you're interested and you're part of that. And I encourage everyone to find their role in public health in their own communities and families and social networks. All right. So next I'm going to share with you, because this is Health Research Live, I'm going to share with you some of the public health research in the Upper Valley. And just like people don't always consider themselves public health workers, even if they are, I think researchers sometimes who are doing public health related research sometimes don't consider themselves public health researchers. I've assembled here a list of topics that we have public health research in the Upper Valley. These actually are all people who've been connected to this program, the Health Research Live program, either previously or coming up. On the top left here, you'll see the topic of telemedicine. We're tackling that topic here in December in this program. So you'll be hearing about some research that's happening in the Upper Valley on telemedicine. We're also talking about vaccines here in November. And in previous sessions, we've talked about rural health equity. We've talked about research on infectious disease. We've talked about vaping in young people with Suzanne Tansky. We've talked about childhood nutrition with Jennifer Emond, and Brendan Nyhan came in. He was talking about communication about the COVID-19 pandemic, but he also does work on communication about vaccines. And De Geisel was here, David De Geisel, talking about COVID-19. He's an infectious disease doc, but he and I actually together do research on infectious disease and drug use. And so all of these research projects that are happening here in the Upper Valley are connected to these different essential public health services. And I will say I probably didn't connect all the lines here. That I probably could have made quite a spaghetti diagram with a lot more lines, because many of these projects are connected to multiple essential services of public health. So this is some of the research going on here. And then in addition to research, we have public health practice. And public health practice is done by many different public health agencies, from the international level to the very local level. So here on the international level, I'm listing the World Health Organization. The CDC also operates both nationally and internationally. And then in this part of the world, Vermont and New Hampshire have active departments of health at the state level. Many of our traditional public health services are delivered at the state level, and Alice will talk a little bit about that as well. And that's appropriate in small states. In other places, you'll see more public health services delivered at the county level or the city level. The New York City has a huge Department of Health, for example, but a little place like New Hampshire or Vermont doesn't have quite as much infrastructure at the very, very local level. That said, we do have local infrastructure. Most of our local infrastructure comes through Dartmouth-Hitchcock. Dartmouth-Hitchcock holds a couple of the contracts and is the fiscal agent over the public health networks for the Upper Valley and also for Greater Sullivan. Vermont has a slightly different structure, which I think Alice is going to talk about in a few minutes. So all of these organizations are the people who are doing public health for our region. And the topics that are international are connected to the international organizations, and the local topics are really connected to the local agencies or the state agencies. I'm also noting here on the bottom left, if you're interested in studying public health, there are a number of places you can do that here. These are not the only ones, but these are right here. Colby-Sawyer College has an undergraduate program, and the Dartmouth Institute has a master's degree program. And there are more. I believe there are also programs at both UVM and UNH. All right. And with that, I am going to pass on to Alice.
Thank you, Aurora, and thanks all of you for coming today to share in this information and learn a little bit about what goes on in public health around here. What I'm going to do today is walk you through some of our local systems or state systems, and if there are questions, please put them in the chat. There's always something that I assume people know or things that I miss. So I hope we have an opportunity to talk about it when we do our breakout sessions as well. Next slide, please. Aurora, thanks. Thank you.
Oh, I got a little lag there.
Not a problem. So again, my name is Alice Ely, and I'm Director for the Public Health Council of the Upper Valley. I came to New Hampshire now about 20 years ago with a brand new master's degree in public health in health education and health promotion, and worked for a number of years with the New Hampshire Department of Health and their public health program, as well as some of their substance abuse programs. And so I had an opportunity to get to know the inside of the New Hampshire system relatively well. It's only been within the last 10 years that I've worked with partners in Vermont. So I won't be able to speak as well about that system, but I've learned a lot about it in the last few years, and we have a really great relationship with partners at the Vermont Department of Health. So as Aurora said, most of the authority for public health in New Hampshire resides within the central state office. There are a number of people working on lots of different programs there. I've listed some here, but this is not an exhaustive list of the programs within the Division of Public Health Services. The ones that I've listed, though, I think are more relevant to our conversation today and some of the partners that are around the table. So of course they do chronic disease prevention and screening. These are some very core public health functions across most jurisdictions: screening, prevention of those conditions, those health conditions and illnesses that cause the greatest harm in our communities. One of the things that they do there is the New Hampshire Comprehensive Cancer Program. They do colorectal screening programs and mammography programs, particularly programs that ensure that low income and uninsured people have access to these screenings when they aren't able to get them from other places. Of course, infectious disease control is on the front of everyone's mind these days with coronavirus. And these are the same folks that are thinking about flu vaccine and hepatitis C and hepatitis A and other conditions that spread very quickly in our communities if somebody's not paying attention. I think these are the folks that are doing a tremendous amount of work right now with COVID-19 testing and contact tracing. They are very, very busy, and that is true in both states. The immunization program spends a lot of time trying to make sure that children and adults get the vaccines that they need. And these are all the childhood vaccines that many of us think about, the MMR, but also the annual seasonal flu vaccines. And today, of course, I'm in Bradford, Vermont, trying to set up one of our community-based drive-through flu vaccine clinics because the demand for these is very high this year, which we're all very happy about. Reducing the amount of flu that we get this year is definitely one of the strategies that we want to put in place to keep people out of the hospital, keep people well, and reduce the confusion between illnesses that are flu-related and illnesses that are COVID-related. Some of the other programs here, I don't need to go into them, but when you see things that are noted in the slides in sort of a off blue color, those are the things that really have more local connection, where that work is really supported by a lot of local organizations and local efforts and local coalitions. So I'll talk a little bit more about those in a little bit. Vermont does, of course, have a lot of this authority at the state level, but they've also pushed a great deal of their program work out to district offices around the state. And each of those district offices runs a number of direct programs like the Women and Infants and Children's Nutritional Support Program, otherwise known as WIC. They have folks within their district offices that do contact tracing for infectious disease. And that includes, and over the years, I've talked with colleagues who have said, oh, you know, I'm doing some E. coli investigations this week, or I'm doing some salmonella investigations. And so that work happens at the district office level in many cases. And those folks are also available and very, very involved in the work we're doing right now around COVID-19. The district offices are also very involved in local collaborations, and I will talk about more of that in a moment. On the next slide, please. I do want to circle back again, though, because The regional public health networks that Aurora described in New Hampshire are connected to the New Hampshire Division of Public Health Services. We are not imbued with public health authority in the traditional sense. There are no laws and regulations that provide me as the executive director or any of the other folks that work through this public health network with authority to make decisions and make things happen. But we do provide a tremendous amount of support to those folks at the local level who do have that authority. And we are an important conduit of information between the state and our local partners. So the state of New Hampshire created these about 15 years ago in an effort to start to build a little bit more capacity at the regional level, particularly around some of these issues of data collection, needs assessment, building the coalitions so that, for example, when COVID-19 occurred, many partners at the local level knew what role they could play and how they could work together to support the needs of the community. So we launched the Public Health Council of the Upper Valley in response to New Hampshire's call back in the early mid-2000s to establish these regional public health networks. The state provided funding for emergency preparedness work and regional substance abuse prevention to support the networks. And we've built out of those programs, asking our regions to also take a role in creating regional community health improvement plans, coordinating the implementation of those plans. We've been very lucky here in the Upper Valley that many of the towns in the region have also helped provide funding support to allow us to do this work and continue to build our capacity. Each region in the state of New Hampshire has built their regional public health advisory councils in ways that really suit their own community cultures and their resources. In the Upper Valley, we have a broad coalition of partners. They're guided by an advisory council of 14 to 18 people who represent very diverse sectors across both our New Hampshire towns and our Vermont towns. And these networks are how New Hampshire has sought to build public health structure at the local level. And the Vermont partners have also seen the value of working with us across a very broad coalition. We gather in meetings about 8 times a year. We have a mailing list of well over 200 folks. And we are able to create a community health improvement plan that's driven by data, but we also have the capacity to respond to things that come out of left field, so to speak, things like the COVID-19 pandemic. And it's certainly changed the way we've done our work over the last 9 months or so. Next slide. I'm not going to read our mission statement, but I just wanted you to know that these are the towns that are in our Public Health Council region. And we focus the work that we do around these areas of collaboration, education, and advocating for the needs of the residents in our communities. Next slide. What we've been doing during the pandemic, and this is where I'm going to tell you about these efforts over the last 9 months. Our public health region has mobilized many partnerships to help address direct and indirect needs that have been caused by the COVID pandemic. First, the pandemic emergency response. We worked with some of our partners, and there are staff within Dartmouth-Hitchcock who do emergency preparedness work on a regular basis. This is their job. And so when the pandemic happened, they had plans and they had relationships that they were able to draw on immediately to get our region prepared for this response. We had one of the first cases in the Upper Valley of COVID-19 in both New Hampshire and Vermont. And so we were the first region to really start pulling these plans off the shelf and pulling people together to say, how are we going to make sure we can keep this under control? How are we going to make sure our community knows what's happening? And I think that we did that very, very well back in early March. We did that through something that is called the Multi-Agency Coordinating Entity, and this is based out of the Lebanon Fire Department. We also were able to pull from this thing called the Medical Reserve Corps, which is a standing group of volunteers, both medical and non-medical, who are able to support things like COVID-19 testing operations and seasonal flu vaccine clinics. So when staff with some degree of training have been needed, we've been able to pull from the Medical Reserve Corps. We've also been part of a coalition called Upper Valley Strong. And this is the group that's not looking at the immediate and COVID related issues, but they're looking at the impacts that COVID has had on members of our community. And this is a coalition of I think, probably more than 40 organizations that have come together to think about how do we make sure that folks have access to food, healthy food, when they are maybe laid off from their jobs, or when children are home from school and learning remotely, when people are medically vulnerable and they need to remain quarantined in their homes or isolated. How do we make sure that they have the things that they need to be safe and to be healthy? There's been a group of folks working on questions of childcare. I hope you remember back in March and April when schools and childcare centers all shut down, there were still many, many people who needed that childcare support. And so a lot of folks have come together to figure that out. So this group, Upper Valley Strong, has coordinated and leveraged resources across many organizations to address the needs of our residents. And one of the projects that I was very involved in was reaching out to all of the towns in our region to make sure that they knew what we were doing at the Upper Valley Strong table, what kinds of resources we could bring to bear to help them, but also to learn about what they were doing and what needs they were seeing in their own communities. We're also very aware, and we're thinking about the downstream impacts of the pandemic. We really don't have a strong understanding of what the implications are going to be for public health. But we do know that CDC has reported declines in things like childhood vaccinations by the start of the summer. And we're concerned about screening for cancer concerns and routine health care for vulnerable people with chronic conditions. And so we're wondering what's going to happen. Will cancer screening rates go down over time? Will people miss preventive dental care? And will that result in more dental issues for people? Will people with chronic conditions delay seeking important care that is keeping them healthy? These are the types of implications that folks who work on public health are thinking about now, and finding ways to message to our communities that it's safe to go to the doctor to get a screening, that it is safe to go to the dentist to get your teeth cleaned or to take care of whatever conditions you have. The messaging is important, and we know that this is going to be a long-term effort to make sure that people are doing the things that they need to do and feel confident that they can do those things, even while this pandemic continues and begins to wane, we hope, within the next 6 to 9 months. And back to you, Marcos, I think.
Yes, thanks so much, Alice, and thank you, Aurora. Because we're such a small group today, we're going to actually forego our small group conversations and just open it up to the larger group today to just go right into the Q&A. 2 questions that we had thought about for everybody to discuss that we can do in a large group right now, which Laura has put into the chat for everybody. Where do you see public health in our community, and where do you think there are gaps in public health services in your community? So I'm going to turn it to start the questions to Alice and Aurora first. And if anybody has additional questions, please put them in the chat and we can help moderate that and get those questions directly to Alice or Aurora. But I'll ask the first question, which is through both of your experiences, Alice and Aurora, where do you think that there are gaps in public health service in our community? You've given us a broad range, but maybe what are the most important gaps that we need to face right now?
Alice, you want to start?
Sure. I think the fact that we have such a robust coalition, we have so many organizations that are working together, that we're very, very lucky. But one of the gaps is that question of authority. Who has the the responsibility and the legislative authority to take a lead role, particularly on the New Hampshire side of the river. There's the Vermont side, of course, has the district office for the Vermont Department of Health, and they're the ones that sort of step up and take the lead. And unfortunately, on the Vermont side of the river, we don't have that. It's not caused huge problems for us at this point, but I think that there have definitely been examples, COVID being one of them, where a greater authority would have made it a little bit easier to rally the troops early on and to be really clear in our relationship with the state of New Hampshire about what we were seeing and what we needed.
So this is Aurora, and what I'll add to that is, one of the things that's not missing here is collaboration. I think there is remarkable collaboration for working together here in our community. And I think that speaks volumes to all of these organizations and people doing this work, that they have found that it's better to work together than to work completely independently. One thing that I think is really challenging in this region is that we don't have really stable, sustainable public health infrastructure. An awful lot of our public health projects here are funded by these sort of one-time temporary grants. And there are a lot of people constantly scrambling to figure out how to do really important things over the long term when a temporary grant expires and there's no clear infrastructure funding resource for sustainable long-term public health measures that need to not be a 3-year long project. Like many grants fund. So I think that's really a challenge, particularly, again, I would say particularly in New Hampshire. I think Vermont has a little more infrastructure than New Hampshire does, but sustainable long-term public health infrastructure is really challenging.
We got a question in the chat about local support for natural healing approaches. And I might transform that question into also thinking about wellness in general. And maybe both could speak a little bit about either alternatives or wellness initiatives that you might have seen come across in the Upper Valley.
It's actually, it's a good point to bring up. As Aurora pointed out, without the infrastructure and without the consistent funding, many of the wellness projects that happen on short-term basis. And then when that funding is out, they go away. And so other than being involved in an organization that over the years has had some funding, for instance, to do tobacco prevention work in schools or substance misuse prevention work with kids, we don't have a lot of support for sort of fundamental wellness. There was for a number of years a coalition called Healthy Eating and Active Living that was again funded through the state of New Hampshire. And when that funding ended, it went away. Now, during the period of time that it was there, they created opportunities, for instance, for restaurants, particularly the more local restaurants, to highlight on their menus the healthier options. So they worked very hard to promote the idea that the healthy choices should be the easy choices for people. I know that we've got local work on things like the Mascoma Greenway, which I would put into the category of wellness promotion, creating opportunities for people to get exercise, to get outside in ways where there are no barriers, let's say for expense, there's no membership required. So there are a lot of things that happen around wellness, but they don't generally happen in a sort of broad coordinated way under one umbrella pushed out for everyone throughout our region. Again, that's one of the gaps that we have. And I would ask Connie if there's more to her comment about natural healing approaches, sort of what is it that she thinks that the public health structure within the state or the region could do to provide that kind of local support? What would that look like if it were to happen? And while I'm asking her to do that. Yep, go ahead.
Oh, I tend to focus on naturopaths or homeopaths, that kind of medical approach to healing. So, and there really isn't much in this area. Just any natural focus on healing.
What would local support look like, Connie?
Oh, I don't know. Availability of those kind of doctors would be nice. And places to get, say, herbs or homeopathic remedies, that kind of a product is not around here anywhere.
Okay, all right, thank you. Another gap that I would want to suggest, and it's less a gap than it is a challenge. What the work we do really needs to be driven by the data. The priorities that we select need to be things that we see creating challenges for folks within our own communities. Data is very, very important. The state of Vermont does a really good job of collecting a lot of data. The state of New Hampshire does a pretty decent job of collecting a lot of data. But one of the challenges that we have constantly is they're not collecting the same data, or they're not collecting it in exactly the same way. And so it's very difficult for us to say, well, this particular thing is happening in Grafton County and Orange County, and we can compare the data, because it's often just different enough that we can't say anything really definitive about what's happening across the state border. And it makes it much more challenging for us to figure out exactly what the issues are that we want to address and how we'll know if we're actually making a difference. Data, of course, is the thing that Aurora does a lot of work with. And so I'm sure she has much more to say about that topic.
Yeah, I would say I think there's a lot of data available, and both the state of Vermont and the state of New Hampshire have done a remarkable job, especially during COVID-19, of putting a lot of publicly available data on fairly intuitive websites most of the time. Occasionally, they don't work perfectly. Occasionally, there's a little more of a lag than we'd want. But I have to say the data transparency during this time has been really strong in both of our states. And I think improving about many different topics, as both states put lots of interesting health information online. Again, like Alice said, it can be challenging to compare across different geographic regions, where they may be collecting data just slightly differently enough that you can't compare across state lines or across county lines or across even school district lines sometimes when some data is collected differently.
Great, thank you both. Since we don't seem to have any other questions in the chat, I do know that there's another slide on here if we wanted to speak to that.
Sure, so this was my final slide, and we always like to give people something that they can do when we present information about public health and what's going on in our region. So I wanted to share with you today a few actions that we hope that you will all take and you will share with your neighbors and your family members and others in your community. You know, what can you do at this point to contribute to our community's health? And of course, much of it has to do with COVID and the pandemic right now. So I just want to emphasize that this is not the time for us to get lax about following the simple steps to keep ourselves safe. We continue to wear masks. Mine is right here for the moment. Continue to social distance, wash our hands frequently and well. Stay home if you're sick, please stay home if you're sick, and follow the local guidance about what is safe, when it's time to go into restaurants, when it's time to do takeout. And I think it's still important to continue to think about the things that you're doing in terms of whether it's really essential or whether it's just something you'd like to do. And if it's just something that you'd like to do, maybe it's still a good idea to put it aside for a little while, or make sure that when you go, you're going at a time that's not so crowded. Also, pay attention to the source of the information that you're receiving. We're in a time of just being inundated constantly with information, and too often it's very contradictory. So I would suggest just bearing in mind that the best sources, the most reliable sources of information on what's going on with the pandemic in our communities and how to prevent the spread of the pandemic is paying attention to the state departments of health in New Hampshire and Vermont, paying attention to the Centers for Disease Control and Prevention, and if you want to go beyond that, to the World Health Organization. Local doctors are great sources of information about what they think is important. If you have questions, reach out to your healthcare providers. But also, please get a flu shot this year. It's very important that we reduce the number of folks who are sick and need particularly hospital-based care at a time when hospitals are thinking again, just like they did last March and April, they have to be prepared for more people coming into the hospital who are very sick with COVID. And we want to make sure they have the capacity to care for those people appropriately. I'm happy to answer any questions anyone has.
Great. Thank you, Alice. In that, one of the other things that we've noted between the two different states, especially recently, is different travel guidance that's also been sort of on high alert, specifically between Windsor and Grafton counties, since now there's somewhat of a divide between the two states in our bi-state region. Aurora, do you want to speak a little bit to that?
I would be happy to. And I'm actually going to stop sharing slides so that I can actually pull up the travel map, because I think it's helpful for us all to be able to see it as we're talking about it. Let me see if I can pull up that travel map right now. All right, so this is the Vermont cross-state travel map. And I don't know how many of you have seen this before, but Vermont's been putting this out, I think, since about June. And it shows Vermont in the blue here. And then it also shows all the counties in the Northeast US and how many approximate current COVID cases the Vermont Department of Health is estimating in each of those counties. And what happened last week that was big news for the Upper Valley is Grafton County turned yellow on this map. And that is really confusing to the Upper Valley. Because suddenly this region that is bi-state, that people are border crossing all the time, our Grafton County, which is a pretty big county, suddenly is in this yellow section of the travel map, which means that Vermont is asking people who are going to Grafton County for non-essential purposes to take extra measures to prevent from bringing COVID-19 into Vermont. And those extra measures that the state of Vermont is asking is specifically a quarantine. And in Vermont, it's you have the option of doing a 14-day quarantine or a 7-day quarantine with a COVID test. And that was really confusing and complicated to the Upper Valley, because what does that mean, especially to a business or an organization like the Montshire that is literally right on the border of Vermont and New Hampshire and has people who come from both counties regularly. It's an extremely confusing public health guidance, people trying to figure out what this means. So one of the things that Vermont is clear about is that it doesn't mean you can't go places for essential reasons. And there's a long list of essential reasons that Vermont has. But those things include school and work and shopping for food and other essential items, healthcare, those sorts of things are all allowed. You don't have to have a quarantine for that. But when this happens, it is really confusing. And especially last week, it was confusing. Now, this map is updated every Tuesday in the late morning. So it was updated yesterday. But before it was updated yesterday, it actually there was a higher rate of current cases in Windsor, Vermont, than there was in Grafton. That is now not true as of their update yesterday. So right now they're estimating Windsor, Vermont has 354 estimated active cases per million, and Grafton has 458 estimated active cases per million. And you can also see here in the hover, if you can see that tiny, tiny, tiny text, you may not be able to on this map, but in Grafton, the cases look like they're rising. They're going up. They've gone up a little bit last week. It's saying plus 3.8% on the Vermont algorithm. And in Windsor, they're going down 25% in the last week. So in one place the cases are rising, and in one place the cases are falling. And I will say that the calculation that Vermont does for these numbers is a little complex. They do document it really well here. There's a couple of links here, one that says complete methodology, and then you also can see the fully aggregated data by county. So they are not using just the counts that New Hampshire is putting out for Grafton County over the population. It's a little more complicated than that. It weights cases that are more current more heavily than cases that are further in the past. So that's some of the reason for the discrepancies that people are immediately seeing in these case rates, is that Vermont is not doing it's not just a straight fraction. The other thing that is pretty confusing to people about this is the idea of using cases per million in this tiny little rural area. I think that really confuses people because there aren't even 1 million people in Vermont, right? And so expressing this number in cases per million confuses people a little bit. Quite understandably. I will say the per million just doesn't matter at all. You could express it, per 1,000, per 10,000, per 100,000, you would have the same results. What Vermont did do is choose this weird threshold of 400 cases per million as the threshold. And they did this way back in Vermont, way back in, I think, June, where they chose that threshold as that's the threshold where we think there's more COVID in that place than there is in Vermont overall. And so we're going to ask people to take extra measures, and specifically to quarantine. And so this wasn't really an issue for our region because none of our counties in this region had cases that were above that threshold until just recently. And as we crossed the threshold in Grafton County, according to Vermont's calculations last week, I think it's caused quite a bit of confusion. And I'm happy to answer questions about whatever confusion people here are having about it, to the best of my ability.
We don't seem to have any questions coming in the chat just now, but I would say from a larger public health perspective, what would help in making there be less confusion? It would be, yes, if all of the states are feasibly aligned, but I think one of the confusing things with all of our bordering states is that Massachusetts, New Hampshire, Vermont, and New York and Maine have different guidelines.
Totally different. Yes, each of these states is doing it differently. Some people would argue for some national guidance on this, right? That it would be helpful if the CDC came out with some national travel guidance. And the CDC does have some guidance, but it by and large says rely on your local public health agencies. That's what most of it says. It says be careful. Here are steps you can take to prevent yourself or others from being from getting COVID-19, but listen to your local health authorities, right? And so that's by and large what the CDC guidance says. So would it be helpful on a national level for there to be some clear national guidance? I think it would make it less confusing for states, right? Where every state has different rules. So for instance, New Hampshire rules, they chose a few New England states where they allow travel without quarantine. And they haven't, as far as I know, I don't think they've changed them in that time, sort of regardless of what was happening. And it didn't matter how red Massachusetts was, or parts of Maine. There was an outbreak in Maine that you could still go back and forth to Maine, right? And I think that's challenging. Some of these decisions are arbitrary. Some of them do need to change over time. And then I can see that Steve's comment, what's also confusing is that some are adhering to guidelines and some aren't. So individuals and businesses and organizations are all, responding to these guidelines differently. And that can be really challenging. You see in your world, you see people wearing masks and not masks. You see people traveling like crazy and gathering and posting pictures on Facebook of big parties, right? You see that happening, and you also see people who are not doing that. And so it can be really, really confusing. And then there are these very specific micro decisions that people need to make of like, do I send my kid to the event they were supposed to go to that's just over the state border on Friday? Right? Can I send my kid? Are they still allowed to go? Right? All of those things get to be really, really confusing. And I think in the last 10 days, it's really come home here in a way that it hadn't been previously.
You know, from a public health perspective, and I'm just thinking selfishly about Norwich and Hanover, which as the Montshire sits, 0.8 of a mile from the border of New Hampshire, and the Connecticut River runs through us, so owned by New Hampshire. So and we're not the only.
They share a school district.
We're one of 3, bi-state school districts with the Dresden School District. What are the chances of larger spread, between these, for example, Norwich and Hanover, or West Lebanon and Hartford? Is it all make believe in between these towns that there's a higher rate between one or the other, since employees are still allowed to go back and forth? You can still go back and forth according to the victims to get food, since not that we have food scarcity in Windsor, but like there are more affordable options in Lebanon, so many people have to make those choices. So in that, it is almost what are those chances of larger spread going back and forth? Not to put you on the spot, or if you
sure.
can't answer
You're
that
asking,
question.
do you think it's a real risk that
Right.
people could spread? I mean, I think first of all, nothing we do is without any risk, right? So, and people have very different perceptions of what risk they can tolerate. So is there a real risk of going from a lower COVID prevalence place to a higher COVID prevalence place? Yes. I would say yes. That's a real risk. What you're doing, what you're doing in those 2 different places, by and large, you could do very high risk activities in Windsor, right, within the Vermont borders, or you could do very low risk activities in Grafton County, right? And so the individual risk you experience probably has more to do with what individual things you are doing than what place you're in right now.
Great. All right. Any other further statements? We have a few moments left before we end for the day. Anything else you'd like to contribute? Okay. Thank you, Alice and Aurora, so much for your knowledge and for your expertise and for sharing all this information about public health. And thank you to all of our participants today. In the chat section, I just put up a program evaluation. We always love to get feedback about these programs and what more we might be able to do out into the future. I'll send that out via an email as well. But if folks would like to just take that, it's a very short survey, just about how this program went today. We do have another program about vaccine research and initiatives that will take place on November 18th at noon. Information about registration can be found on the Montshire's website, www.montshire.org. And with that, I'd like to thank all of you for coming to Health Research Live today. And again, thank you, Alice and Aurora, for your contributions. Have a wonderful day, everybody.